morning, everyone. We're asking you to take your seats so we can get started. Wow, that happened really quickly. If that could only happen with my kids, I'd be so much happier. So good afternoon, everyone. My name is Anna Thomas, and I'm the Public Health Director here at the City of Manchester. We welcome you to our community conversation on developing a safety net for Manchester with growth, resilience, integrity, and tenacity. We're joined here today not only by our esteemed guests from San Antonio, but which is also, by the way, I figured out is the 7th most populated city and the fastest growing city in the country, 2 million people. But it's also one of the many cities that we are starting to learn from on a national scale to help inform our local efforts in New Hampshire. We're also very fortunate to have a wide array of people here today from all over the state of New Hampshire. We are welcoming representatives from the city of Nashua, from the city of Concord. I think we have some folks from the Seacoast, from some of our state agencies. We have several aldermen. I thank you for coming. Our drug czar from the governor's office, and some other folks I am sure I'm forgetting, and I cannot thank you enough for taking time on your busy schedules to be here. But in order to welcome you properly, I would like to be able to introduce you to our Honorable Mayor Joyce Craig, and if I could just do a quick introduction, Mayor, so you can really appreciate the leadership that we have that is guiding our efforts in the city. Born and raised in Manchester, New Hampshire, Mayor Joyce Craig grew up in Ward 8 and is a graduate of Manchester Public Schools, having attended Green Acres, Southside, and Memorial. After she earned a degree in business administration from the University of New Hampshire, and the mayor worked as a marketing director for 15 years, where she developed strategic plans and managed multi-million-dollar budgets, as she does now. Mayor Craig began her public service in 2007 when she ran for and won a seat on the Board of School Committee in 2009. She won a seat on the Board of Mayor and Aldermen and served 3 terms representing Ward 1. On November 7th, 2017, Mayor Craig became the first woman to be elected mayor of Manchester. She was sworn in for her 2nd term on January 7th, 2020. The mayor and her husband, Attorney Michael Craig, have 3 children, William, Sarah, and Catherine. The mayor is also an avid runner who's completed 14 marathons in her spare time, including 10 consecutive Boston marathons. Mayor, if you would do the honor of joining us today.
Good afternoon. I just have to say I haven't been running marathons lately, unfortunately, but thank you for that nice introduction. It's such a pleasure to be here with all of you, and I just want to thank you for taking the time to be here. It's so important. I do also want to start off by thanking Anna, Jamie, and Phil, and the entire health department for all that you do and for coordinating the meetings this week and convening us today. I also would like to thank Alderman O'Neill, Barry, and Roy, and the many department heads from the City of Manchester who are joining us today. And I'd also like to thank our hospitals, CMC, Solution Health, and Dartmouth Hitchcock, for your partnership in this initiative. Without you, this collaborative work would not be possible. And finally, I want to thank the folks from Be Healthily for traveling to Manchester, for listening and meeting with so many of us to get a better understanding of what we're doing locally so that you can help us become more effective and efficient in helping the individuals in our community who need our help the most. The addiction epidemic and homelessness are issues that communities across the nation are facing. And while we've seen their effects here in the city and in the state, I, along with everyone in this room, are committed to facing these challenges head on to ensure that we're helping the individuals who need our help the most. And for years, agencies across Manchester have worked together to find solutions to these complex behavioral health challenges. There's exceptional work being done, and progress is being made, but we know there's so much more work that needs to be done. Ending homelessness and finding long-term solutions to the addiction epidemic is a community-wide commitment. The solutions won't happen overnight, but I'm confident with the quality of organizations and city departments who are working together and involved, and the compassion of Manchester residents, we'll work collaboratively to make a positive difference. So again, I want to thank you all for being here. I look forward to the conversation and to the work that we'll be doing together.
Thank you, Mayor. So let me just sort of ground us today as we embark upon the next couple of hours. I will be remiss if I don't thank some of the funders, including Catholic Medical Center, Elliott Health Systems, Dartmouth-Hitchcock, NACCHO, and CDC. They've all come together to make this event happen and make the work happen in Manchester as well. So one of the things that we also have to think about is how does this kind of body of knowledge today translate to what we already know is happening in the state of New Hampshire and in some of our local communities. So just for comparison, even though San Antonio as a city is much larger than any of ours and even ours collectively put together, there's similar benchmarks in some regards. So our violent crime rate, especially for Manchester and San Antonio in particular, is sort of tracking at 592 as a rate per 100,000 population. And in San Antonio, it's slightly higher. It's about 649. In some of our surrounding communities, Nashua is at about 140, about 239 in Concord, and about 378 in Rochester. So we're kind of all over the map. Some of our communities are at different paces. But part of what we also have to look at is who is residing within our communities. Childhood poverty persists in Manchester, 21.4% versus 27.2% in San Antonio, and 23% among our 500 largest cities across the country, about 16% in Nashua, 10% in Concord, and 16% in Rochester. But the more important kind of measures that we're concerned about today are the things that really translate to our health status. So understanding when we are in mental distress or when we are tracking overdose deaths. These are significant benchmarks that really quantify the overall health of a community. So we have many residents, unfortunately, especially in certain neighborhoods in the city of Manchester, who are experiencing frequent mental distress, and that's defined as having half a month or more of having bad mental health days, if you will. So in Manchester, we're about 14%. San Antonio is slightly less, about 13%, and about 13% in Nashua. But in some of our neighborhoods, we're as high as 20%. You know, lots of people really grappling with points of crisis in their life. Our greatest disparity, however, is really in our overdose deaths. And this is not new knowledge for the people in New Hampshire, but we have a rate of about 68 per 100,000 compared to San Antonio that only has 6.8 per 100,000, which is incredibly dramatic. And Nashua kind of meets in the middle at about 40 per 100,000. So the other aspects of our community is the fact that we are also responding in a very real way every day to people who need us most. And American Medical Response is out there saving lives along with our police and fire departments. AMR has responded now to 3,682 overdose calls in Manchester, including 355 fatalities. That's larger than some of our towns in the state of New Hampshire. Over 10,000 milligrams of Narcan have been administered, more than any other community in New Hampshire. Thousands of individuals have come through our Safe Station model, which has now been replicated in cities across this country. And over half of them are coming from communities outside of the city of Manchester. It's really important to understand that. In addition, our Healthcare for the Homeless program through Catholic Medical Center serves on average about 1,800 unduplicated adults and individuals experiencing homelessness. And the Manchester School District at any given time identifies and tracks about 600 homeless or displaced students in a given school year, half of whom are of elementary school age. We are currently filling up our emergency rooms with large levels now of people with very complex needs. And at some points, we're tipping the scales facing diversion levels. And this is now sort of the new sort of state of affairs in our community. And not only that, our homeless shelter, emergency homeless shelter, New Horizons Family in Transition, who for many, many years have taken care of our most vulnerable, now we're at capacity every single night. So 138 individuals filling up the beds, 30 of whom will sleep on mats on the floor every night. And because we have an amazing faith community here, we are now seeing a response from our faith leaders to come in and assist us with the overflow of that shelter, and we're standing up surge warming stations. And every night we may take on an additional 10 to 20 individuals in an effort to prevent loss of life due to the cold. So this is our everyday, and it's unfortunately what is happening not only in Manchester, and it's why we felt it really important to invite these other communities in, because I know for a fact that many of you are grappling with some of these issues, maybe on different scales, but it is all in our future, all in our future work. So right now, we are challenged with today and what these experts can help bring to our community. So they're here to challenge us, to inspire us, and to remind us that we're not the only community in this state or country grappling with these issues. So I'm giving you 3 directives for the morning. So the very first one is be open to learning. If we're going to be a learning community, we have to expand our horizons beyond the boundaries of our cities and of the state of New Hampshire. There are lots of lessons learned and communities who have gone before us, and we continue to bring them in. Last summer, we brought in Dayton, Ohio, to look at our opioid epidemic. And I think we need this inspiration more regularly, because there are sister cities way beyond New England who we could be learning from. Number 2, make a concerted effort to network. So this is the time that many of you already know each other, but if you haven't, take a moment, try to introduce yourself, because we are all peers in this together. And if we're going to find a solution, it's probably in this room right now. So let's capitalize on the collective knowledge and experience and expertise that we all can bring to each other to help get us out of this plight. Number 3, wash your hands. So, as public health director, I get to use words like infectious. So right now we are in the height of cold and flu season and all kinds of things out there. And you're all shaking hands. I did it too. So what I'm going to expect that you do, this is your 3rd directive, is that before lunch is served and you start putting your hand close to your mouth, you go to the bathroom and you wash your hands. And you wash your hands for 20 seconds. And what that is you have to sing happy birthday to yourself twice. So I want to hear out of the bathrooms, happy birthday to me. Like, I want you to go through the motions and get it in your head. If you have children, family members, have them wash their hands. That's my final take-home message. So wash your hands. So without further ado, let me introduce one of our speakers today. And we are so fortunate to have these folks with us. They've come to Manchester already, and so this is now the 2nd leg of their journey with us. And let me just start with Carla Ramirez. Carla Ramirez, Managing Partner for Be Healthily Consulting, LLC, and a catalyst for transformation to excellence in behavioral health care. Carla Ramirez provides organizations seeking market leadership and clinical excellence with the tools to implement the vision and innovation necessary to disrupt and lead the market into the future. Over 15 years executive management experience and accomplishments in behavioral health care, and with a track record of success in operations, leadership, and strategic planning and marketing. Carla's passion for getting people the right care at the right time at the right place can be traced back to her role as Vice President of Restoration Services at the local mental health authority for Bexar County, Texas. These programs are constantly visited by thought leaders throughout the country and are a model of care in jail diversion space. So Carla, would you do us the honor and come to the podium? Thank you.
Thank you very much. Good morning. It's an honor to be here. Very much looking forward to sharing a little bit of our knowledge and also hopefully inspiring some of the work that you guys are already doing. I've been very impressed already with just the diversity of the group of people in this room. I mean, it's incredible. We have healthcare, we have first responders, we have police, we have payers, we have government. I mean, we have everybody that we need in this room to kind of get some of this work done. And so you guys are already way ahead of the game. I want to thank the mayor and the healthcare systems for supporting this effort and really taking the lead on a lot of this work, and everybody else that's really supporting it. It's really impressive. And y'all are not the only community that is struggling with this. I think almost every community is struggling with this in some way, shape, or form, and everybody's just in a different place with it. So I'm going to share a little bit about our journey that is now kind of recognized as a best practice. We didn't know it was going to happen that way at the time. We were just trying to take care of our community. And we just, over years of this work, we eventually kind of became recognized for it. And so now we kind of go around and help other communities with this. Just a second. Hold on. Thank you. Okay, so thank you. So we're trying to work on building a safety net with grit. Grit is one of the new buzzwords. And basically the idea here is that what the new research is showing is that you need grit in order to be successful. And so I just felt that that was very fitting for this community because you are in a stage of growth. You're growing very rapidly. You need resilience, right? And you guys are a very resilient community already. And integrity is critical, right? And part of integrity includes transparency, right? And that's something that everybody, when they're in this stage of the game where everybody's needing to share their information, is really hard because you have to have trust. You have to build that trust. That takes time. And tenacity, right? Tenacity is a critical component to success. Many of you are already very successful and you already know that. So how do you create that within your community? How do you create one of the people that we met with this week said something that really resonated with me, which is we're really trying to create a community of recovery. And I really loved that. I thought that was a great way to say it because people that are in recovery and that are working for sustainable recovery where they can be contributing members of the society, it takes time for that, right? And it takes lots of different components. It's a very complex situation that they're in, and it takes a lot of different pieces to that puzzle. It's like baking a cake. You're going to bake a cake. You can't just like throw all the ingredients in there and just whip up a cake. You need to measure it and you need to do it precisely. So it's hard. I'm a terrible baker. Like I can't bake a cake. So, it's not something you can do the first time you try, right? So this is an effort to end homelessness. While that's not the only focus, we're really focusing on high utilizers, which I'll get to, but homelessness has been one of the issues that has been mentioned to me quite a bit in many of our discussions. And we want to do that by diverting the highest utilizers of the highest cost services in this community. Because and I will get to that, but if you look at the number of people that you're talking about, it's a very low number of people that are utilizing the highest number of services, and they're usually the most expensive ones, but it's really unnecessary. Because if you kind of used more coordinated system of care, you wouldn't really need those services, and you could probably be much more effective in helping them get where you need to get them. Switch slide. Thank you. So who are we? We are a team that works together now. There's several of us in the room. And what we do now is we work kind of go across the country and help different organizations, cities, counties, payers, systems with these kinds of efforts. But it has really been our life's work to kind of help the people that are kind of the ones that really don't have a voice, and we really need to figure out ways to kind of improve the safety of our communities and also reduce waste is really what we're trying to do, and find efficiencies and be more coordinated in how we help people. And now this has become kind of a very, very big topic in many ways. So that's who we are. Okay. So the Bexar County model, before I show this video, it's kind of a slow video. It's not the best quality, but it does show a little bit about this model of care that people tend to talk about a lot. And it's been very efficient. It's an integrated model, and police love it because they can drop the person off and be back on the street in 5 minutes. And then we had all kinds of different professionals there to be able to triage and determine the best level of care, the most appropriate place for the person, everything from sobering to detox to crisis. So it wasn't put in the officers or first responders' role to determine, is this behavioral health, is this substance abuse, is this homelessness, like what is this? It was, this person needs help and jail is not the place. Jail is very expensive, and an ER is not the place because they don't really need that level of physical health care. And we also had primary care and injured prisoners and all kinds of things. You'll see it on the video. And it just was a great solution with kind of what acute care services would be, and then also ambulatory or outpatient services. So it's a very comprehensive continuum of care that served all types. There's no wrong door. So let me show you the video.
That's 70-20 minutes. We're on the way to that phone. Hey, sir, my name is William. Are you okay? Can you focus on me? Focus on me. My name is William. This is my partner, Jesse. You're not in any kind of trouble. We're just here to help you today. Okay, will you let us help you today? Can we help you up, or do you need help? Okay, we're going to help you up, okay? You're not in trouble. We're just here to help you. Okay? Good, good, good. We're going to go to our car. Good. There you go, bud. Good job. Watch your head. Watch your head. Good job. Hey, partner, so what are you thinking? What do you want to do with him? Where do you want to take him?
He's mentally ill, he's injured. Instead of taking him to jail like we have in the past, we have the restoration center now, which would be a great place for him. They could provide him those services he needs all in one place. Why don't we take him there?
I agree. Let's get him there, man. Get him some help.
Let's do it.
We knew there had to be a better way. The Restoration Center was opened in 2008 with a simple mission: provide a one-stop shop to treat those in crisis so they can stay out of jails and emergency rooms. Since its creation, the Center for Healthcare Services has diverted over 60,000 Bexar County residents into treatment programs, saving taxpayers over $50 million. The sobering unit is designed to take inebriates off the street and completely bypass the judicial system. Law enforcement simply drops off patients who are monitored by EMT and recovery support specialists until they sober up. Motivational engagement is utilized, and multiple admissions are never viewed as a failure. Patients are treated with dignity and respect, whether they're here for the first time or the 100th time. The center's residential detoxification unit, Detox, is a licensed, accredited 28-bed facility offering medical oversight and recovery support for people withdrawing from addictive substances. Residencies are typically 3 to 7 days, but will vary depending on the individual patient's symptoms. Detox helps patients complete a safe withdrawal from alcohol and substances, encourages them to continue substance abuse treatment, and motivates and empowers them to develop a healthy lifestyle. The Crisis Care Center is a 16-bed walk-in mental health clinic that's open 24/7. With on-site direct care staff including psychiatrists, licensed clinical social workers, licensed professional counselors, registered nurses, and licensed vocational nurses. The Center for Healthcare Services also provides crisis services through the Crisis Hotline with mobile crisis outreach teams. The Minor Medical Clinic offers sutures, x-ray services, and medical clearance for those who need minor medical treatment before being transported to jail. This service is designed to reduce ER wait times and get police back on the street. The clinic is open 24/7. Opioid Addiction Treatment Services, OATS, is a licensed and accredited outpatient narcotic treatment program for people addicted to opioids, such as prescription pain medications and heroin. Participants must be at least 18 years old, meet diagnostic criteria for opioid dependence, and have a 1-year history or more of opioid dependence. OATS follows the Texas Department of State Health Services substance abuse guidelines for determination of priority population regarding admission, pregnant IV drug users, pregnant substance abusers, IV drug users, parents with kids in foster care, and honorably discharged veterans. The newest addition to the Restoration Center is the Diana M. Burns Banks, MD Center Care Clinic, an innovative new healthcare clinic offering primary care services to people receiving treatment for mental health and/or substance abuse. The clinic houses 4 exam rooms and 7 staff members, including a medical director, physician assistant, and nurse practitioner. Providers oversee a wide range of medical services from minor procedures, including well women checks, and preventative vaccinations, to hypertension, diabetes, and other acute and chronic conditions. In addition to the programs you just toured, the Restoration Center offers intensive outpatient substance abuse treatment, HIV prevention, intervention, and outreach, Mommy's program for pregnant IV drug users, drug court, U.S. probation program, ambulatory detoxification. We also operate the Josephine Recovery Center, an off-site 16-bed crisis residential and respite facility for men and women focused on providing critical coping skills to sustain functioning and reintegrate in the community.
For quite some time now, it's been my privilege to have been a judge in Bexar County, but I'm tired of putting people in jail. Fortunately, here in Bexar County, we've got the Restoration Center, and through their good work, we've returned 60,000 people or more home to their community, where they live healthy and productive lives. The Restoration Center has helped us save millions of dollars, money which otherwise probably would have gone to building a new jail. My only hope is that one day every other judge has the same option that I do, a safety net, and they'll call it a Restoration Center, because it is.
For more information on the Restoration Center and other programs offered by the Center for Healthcare Services, please visit our website.
Okay, so, I think we have to, sorry. Oh. Hello? Okay, sorry. So I know that's a very long video, but I thought it would be helpful for you guys to get a visual idea of the kind of amount of different types of services that were developed under this. We didn't start out with that. I know a lot of people are like, we don't have the money for that. But our fearless leader, who is back in the back, Leon Evans, was kind of the one that helped kind of figure out how to leverage, blend, braid, and integrate, is what he says, funding to be able to develop this. It wasn't one funding stream or another. We had 92 different funding streams and a lot of relationship building and a lot of need. So this is kind of just like a visual picture of what that community kind of process and model looks like, and you'll see a lot of other partners in there, much like the people that are in this room today. And it started, and I'm going to get to that, but it started with a lot of data sharing and a lot of collaboration and a lot of work, a lot of effort. Next slide. So this is, and I know that y'all's handouts are very small, and I'm sure we can share electronic versions of this, but this is a larger picture of the Restoration Center in terms of where it is located with respect to what's called Haven for Hope, which is a very large also model of care for homeless populations. And what's great about it is that it's right across the street. And the reason for that is that when the homeless model was first built, they were having a lot of issues with that population because they thought, oh, we'll just give them housing. And they didn't really think about the treatment piece that was really critically important. So, you know, you give people housing and you don't give them treatment, what's going to happen? They're not going to make it, right? So Leon met with the people who were involved in this project and said, like, you're going to fail if you don't, you know, address the need for mental health and substance use disorder treatment. And they listened to him, and they figured out some of the funding to build the building. And then this amazing partnership was developed where there was just a very fluid referral process that was developed, also sharing of electronic records to be able to seamlessly refer back and forth. And so that is a huge reason why this was such an effective program and continues to be so. So, cost savings. What you'll see is over 8 years. At the bottom, you'll see 5 because the data after the 5 wasn't, it wasn't really easy to get the integrity of the data. But you'll see a huge amount of savings at the bottom. It's about $96 million to the community, and you'll see at the top county and then city savings. So it's quite a bit of money, and quite a difference that has been made. And that money, you know, as money was being saved first year, then more people were kind of coming to the table to fund this. And, you know, this is a state that didn't expand Medicaid. So I want to say, I don't have the numbers in front of me, but more than 80% were unfunded people. So you're talking about a population that didn't have any kind of funding stream associated with them. Okay, so these are kind of the results besides money that were kind of reached with this program. And, you know, not only was it that we kind of improved the safety of the homeless population, we also improved efficiency for the police and the sheriffs, and also for first responders. They were able to kind of get back to kind of what they felt like was more their role. We reduced inappropriate incarceration and inappropriate use of emergency department for kind of people that didn't really need that. And we increased efficiency and effectiveness of public money. So everybody was kind of happy. So here's some more very specific information that resulted. So you can kind of see what the cost of jail booking was and then what the cost of diversion was. It's a huge difference. I hope you can read it, but it's like 20-something $100 versus a couple hundred or several hundred. And ER utilization dropped by 40%. And all of this data was not just our data. We actually had a data integrity team that was done by the university, so it was not us, who validated all of this. They took everybody's data and made sure that it was valid. So this isn't us coming up with it. Okay, so high utilizers. Now I'm going to kind of go into, when you look across the country at the best programs and what they kind of have in common, what are the common threads, these are kind of the things that is recommended for you to focus on. So high utilizers, which, you know, Medicare calls them high cost, high need people. This is people with very complex medical behavioral issues that tend to utilize these high cost services, but mainly because of the fact that most systems are pretty fragmented when it comes to their care. And so this is just the easiest route for them to kind of get what they need, but it's not really effective in terms of serving the actual needs. You can really be more effective in a much lower cost kind of way if you work together. Okay, so healthcare expenditures, as you all know, are a huge driver for budgetary pressure on states. And so finding sustainable healthcare solutions has been an area of focus for many years, most recently, and will continue to be. It's one of the largest contributing factors to the GDP and is continuing to grow. A large amount of the Medicaid budgets are used to serve a very small amount of people. And the last study that I read was 5% are costing 50% of the spending. So if you look at kind of what kind of complex issues they have, 80% have 3 or more chronic health conditions, 60% have more than 5. This is from HCUP data, so it's well documented data. And a majority of people with mental health and substance use disorder challenges, a majority of these people have mental health and substance use disorder challenges and don't have a lot of access to care. So this kind of goes on, but to really say that the issues are also related to social determinants of health, specifically housing, nutrition, trauma. ACEs is a big focus, which is a assessment tool to determine if somebody had an adverse childhood experience. And a lot of research has kind of shown that that leads to chronic health conditions later. So there's a lot of work being done in that space. And that also kind of, in our population, I don't have the actual data with me, but it's ranges from 60 to 80% of those people will later develop a chronic health condition. So it's really, this is real. This is healthcare. And so it's wonderful to see all of the healthcare providers here and at the table and willing to work on this that has traditionally been considered just a social issue. Okay, so super utilizers, they tend to have more hospital stays, longer stays, and higher hospital costs per stay than a non-super utilizer. And regardless, and they're also, their 30-day readmission rates was 4 to 8 times higher. Now this is 2016 data, so I'm not sure where it is right now, but that's what it was at that time. And for privately insured folks, it's even higher, which makes sense. Go ahead. So if you look at the top conditions for super utilizers, it'll include things like septicemia, pneumonia, and UTIs, which is also very commonly found in people with mental health and substance use disorder. Septicemia is very commonly seen in people with IV drug use issues, as well as like osteomyelitis, endocarditis. These are very expensive medical conditions. So a lot of times, like in the data, you may be looking for diagnoses that are related to opiate use disorder, but if you look at those diagnoses as well, like osteomyelitis or endocarditis or septicemia, many times that's where you're seeing the cost, and it's not necessarily on the behavioral health side, but it's on the medical side. And also, mental health and substance use disorders are also among the top 10 diagnoses for this population. Okay, so in December of 2016, the Cures Act came into play. And that was also, besides Affordable Care Act and parity laws, which the parity laws, what they did for behavioral health was they came in and kind of made it where behavioral health treatment had to be reimbursed and compensated at par with medical and surgical benefits. So this was kind of a huge deal for those of us in the behavioral health world, because now it says, okay, if you have a behavioral health issue and you need treatment, then if your insurance company has that as a benefit, it has to be reimbursed, and the benefit has to be similar to your medical and surgical. So no longer can you have limitations for days that are not the same as your limitations for your medical or surgical like it used to be. It used to be very different. So if you needed treatment for a substance use disorder, and it used to be that you would have to have all these kind of things. There was limitations on the number of days you could get treatment that were much stricter, and there used to be limitations in terms of what type of treatment you could get. You had to fail first. It's called the fail first kind of thing. And so you used to have to fail this type of treatment before you get that type of treatment. All of that is now illegal, and you can't do it. So it's really changed kind of the dynamics, and it has provided more access to care than ever before. And so what the kind of Interdepartmental Serious Mental Illness Coordinating Committee that was created out of the Cures Act, kind of their focus are these things, right? So strengthen federal coordination to improve care, improve access and engagement to treatment, make it easier to get care, close the gap between what works and what is offered, increase opportunities for diversion, and develop finance strategies and increase availability and affordability of care. So one of the things that recently came out of that is to develop a continuum of care that includes adequate psychiatric bed capacity and community-based alternatives to hospitalization, which I know is every community, it's not every, there's a couple that actually don't have a bed capacity issue, but I definitely know here you do. And also the community-based alternatives is something that you guys have amazing services. I've been very impressed with the type of innovation that is going on, but it sounds to me like there's certainly a capacity issue and also maybe some opportunities for better coordination. And psychiatric crisis response using least restrictive. So you guys have some amazing, again, crisis services, but also it seems to be there's some sort of capacity or coordination opportunities that could maybe improve that. And so this particular committee is kind of, there's been like several funding opportunities that have been released for this. And I don't see why you guys couldn't, as a community, go after some of this funding. So these are kind of the best practices to kind of create a crisis bed database. And what this is this will help a community determine what is the capacity. So not just for psychiatric beds, but all the beds. So homeless beds, respite beds, every type of potential capacity that you could have. This would be a database that you could actually share and really figure, have an ability to refer and have it be a really good referral, a warm referral. So this is really important, and I know over here you've got live free and die, or live free or die, and so there's a lot of limitations in terms of, yeah, live free or die, sorry, which for me has been very refreshing because we live in Texas and we have a lot of laws again. But so you guys, the data sharing is a big piece that, you know, there needs to be some work done to that, to where I get respecting people's privacy. And I mean, I'm a substance use disorder girl, so I totally respect that. But at the same time, you need to be able to share information in order to coordinate care. I mean, that's the whole reason why HIPAA was created. So these are some of the best practices that are being recommended at a federal level. There's funding for this. So this would be an area that I would highly, highly recommend. So this is an example of what Georgia did in terms of how they kind of mapped out their crisis continuum of care. And this is one of the first things that I'm going to be recommending that happen here, is that some mapping occur of what your current continuum looks like, what is the flow, what is the capacity, and even if you don't have a database, just kind of working on how to do that here, and really getting a handle on what is all the capacity that we have, and how do you access it, and how do you refer, and what does that look like. And maybe if you guys come to some very concrete solutions to that, that's going to probably open up more possibility. Okay, so the opioid crisis. The opioid crisis has been quite a big of an issue well, I want to say it's been an issue for 15 years, but I think it became a much larger issue more recently. And here in this community, it seems to be quite a significant issue. And so there's so many best practices, and you guys are doing a lot of them. I've been very impressed with some of the work that's happening in the ERs and some of the work that's happening in your crisis response systems, but also it's becoming a more lethal situation here. So that is also an area that I think needs continued work. So this is another example of another community that that we worked on, that if you kind of look this up, you'll see so much work and so many publications that have been done on this community as well. So I wanted to kind of, instead of only talking about Bexar County, throw something else in there. But this community, you know, they started out small. If you look on the you know, the 2013, they just started with visioning. And slowly but surely, they slowly moved up. And the last time that Leon went out there, he kind of met with the legislature, and they got a ton of more funding. And now it's a big collaborative with Via Christi, which is one of their big health systems. And it's pretty impressive. Now they have a restoration center-like facility. And if you look, I think the last, there's a report that was just done by one of the big groups. And you look at the cost avoidance, it's pretty impressive. Very similar to ours. And just if you Google it, you'll see it. But you can see, what I wanted y'all to see with this is, you know, you don't have to start big. You can start small. So homelessness in Manchester, a large amount of the money allocated for homelessness is focused on housing and healthcare. So those two kind of go together. And y'all probably know a lot of this already, but I was really surprised to see that while Manchester only has 8% of the population, they have 30% of the state's homelessness. That was kind of shocking to me. I was like, wow, that's a lot of the percentage of the homelessness, being that they have such a small part of the population. So that means that you guys have a pretty serious issue. And then 46% of those have a severe mental illness or substance use disorder. So I think the national average is more closer to 30. So that's higher. And it seems like there's, again, like I said, an issue with coordination. So as you guys know already, housing as healthcare is kind of a buzzword, and a lot of people use it, but it really is. I mean, you need to have housing if you're going to have healthcare, and it's a challenge because traditional payment models don't, healthcare payment models don't cover brick and mortar. And but there are some innovations that you can use to kind of leverage that. And so I really urge everybody in the room to kind of think about how can you be creative and create housing as a solution for healthcare. Okay, so what works? So the first one is you need to generate community support, and it looks like that has already happened here, and I don't think that that's, you always need to do that continuously. You want to definitely kind of market, if you will, what you're doing and sharing that and getting more and more people on board all the time. And you want to tell the story, right? And you want to try to use data to do that. That's always the best way, is using data to tell your story and to demonstrate the need. Because it's one thing anecdotally saying, oh my gosh, our ER is always blah, 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 versus showing that through data. And then really identifying the people that you're trying to serve. So that's also, again, using data to really kind of narrow this population. Really, if you start with the high utilizers, you can make a very big impact. That's low-hanging fruit, and the cost savings will be amazing, and that's something you can really demonstrate and show, and that will lead to more funding. But again, you really need to use data for that, and by crossing your data, so criminal justice data, hospital utilization data, social service data, and then homeless provider data. So if you can figure out a way to cross all of that and find this common group that's utilizing all of those services, which there's many models of care for that, and I'm happy to share those, but you can also find them very easily. That's the best thing to do, and use HIPAA as a tool versus a barrier, because HIPAA was created to make a person's information portable because it's their information. It's not ours, it's theirs. So that was the purpose why it was created. So if you go to this website, you can see lots of opportunities to get some help with that. So, develop your diversion strategy. And a lot of people use diversion in terms of only criminal justice, but it's diversion to high-cost services. So obviously emergency departments are a big one. That's, several $1,000s for each episode of care versus, a couple $100s. But these are some examples of some of the things that you would do as a diversion strategy, so before the intervention, before they go to the ER or to jail. And Joe's going to talk more about that. So then you need somewhere to divert to. And you guys currently have the the hub model, and it seems to be, maybe with some tweaks, if you had maybe a hub where people could drop off to, and it could be maybe a little more comprehensive, and maybe you could do some work there. But here's some other kind of best practices that have been done, and the Restoration Center was that, I guess, would be kind of that hub where, just have them go there, and then within 15 minutes to 2 days, a disposition would be determined, or they would be stabilized and they would go home, or they would be put into the right place where they needed to be, instead of an inappropriate place that they'd be then stuck with for a long time. So, housing, there's different housing opportunities. Supportive housing is a good one. Housing First is another option. Right now, I think in this community, what I've heard is there's, people that have vouchers for housing that they can't use because of the cost of housing. And of course, then, the money that they make won't cover the difference between the voucher and the rent. And so there's quite a bit of opportunities that, if you put some of the smartest people in the room that are probably all here today to kind of come up with some of these solutions, I think there's quite a bit of models that could be looked at and kind of seen as ways to kind of come up with your own model that would fit best in this community. Every community is so unique. You can't just like, oh, we're going to copy this one. You need to come up with your own, guided by best practices. And then you want to initiate and deliver ongoing services, right? You can't just like deliver the initial crisis services and then just leave it alone. That's why you need long-term housing, you need long-term services, long-term mental health treatment and substance use disorder treatment. Some of these diagnoses, whether it's a substance use disorder or a mental health disorder, is just like diabetes or asthma. I mean, it's a lifelong disease that needs to be managed the way that you might manage other chronic conditions. So people that manage those on the medical side have amazing practices on how to manage those. They have great models of chronic condition care management on how to do that on the behavioral health side. And on the behavioral health side, they have excellent techniques that they use that could be used on the medical side. So it's just really learning each other's language and figuring out how to best do that. And there's so much comorbidities between somebody with severe mental illness I think the likelihood is, I'm trying to think of the data, but it's somewhere between 30 to 50% likely to have a chronic medical condition. So asthma, diabetes, there's like a top 10 list, and those are expensive as well. And if they're dealing with their mental illness and they're not having treatment, they're not dealing with their diabetes either. So also, there are opportunities to leverage funding to optimize care, and that's critically important as well. And it's difficult. You have to really think outside of the box when you're doing this, but there are, especially with value-based purchasing and different alternative payment models, there are quite a bit of opportunities to do that now if you get the right people at the table. I'm working on one right now with a managed Medicaid payer in Texas, and we're working on kind of creating a different type of payment model for a very specific group of population who is very expensive. And a lot of these social determinants of health are coming into play with that contract. And really the model is based on outcomes instead of services. And it's, working out well. And the providers are happy, the payer is happy. So there are opportunities for that. If you just kind of try to think outside of the box and try to look at what is the goal and collecting data to kind of show the outcomes. That's, again, it's back to data. And that's all I have. Any questions? Mm-hmm.
Yeah, three-part question. I've been following this closely as a layperson, definitely not an expert. So the three-part question is, I'm somewhat familiar with Housing First.
Great.
I did see an article recently critical of it in that most people are going to be fine with Housing First, but you have this small minority of people who are violent and seriously mentally ill. And to try to bring it into New Hampshire, for instance, you had 2 murders in government housing in the not-so-distant past. And I guess the criticism in this article was that these people who are violent are going to terrorize their neighbors. I mean, how do you identify them and what do you do with them? That's my first question. And my second question is, as far as finding housing, the problem, at least in this area, is since the Great Recession, developers don't want to build affordable housing. They want to build housing with the greatest profit margin. So how do you overcome that hurdle of finding, because we have, I think, a 1% vacancy rate in Manchester, so how do we find housing that's affordable that we put people in? Also, how do you deal with people who might be problems? You're moving, some people are just moving the problem to housing. So
Right. So to answer your first question, violence is a crime, whether you're whether you have a mental illness or you don't. And so if somebody is violent and is engaging in criminal activity, then that needs to be addressed appropriately. And diversion is not focused on people that are committing serious crimes. It's more focused on people who are just put in jail as a more convenient way because they're committing very low-level crimes because of their mental illness. So people that are dangerous are not the type of people that would be appropriate for these kinds of programs. Those are people that are addressed in different ways until they're not dangerous or until they're stable. So that's not the group of people that would, be eligible for this kind of setting. But the affordable housing issue is a big issue here, and there needs to be some innovation done. I don't know enough about the specific details about each building and what the cost is and who's coming to the table and is open to. There are quite a bit of innovative programs around the country that are addressing this, putting private investors together and subsidizing some of the funding for housing through different governmental organizations and also foundations. And so there are opportunities for that. It's just kind of getting the people together to work on it and come up with a plan. I've got a little bit of time, yes.
Curious about the regulatory foundation that supported that county model.
Sure.
And what was the provider type? And how did you blend different kind of specialties into some, I see, I know it's accredited, but accredited as what?
Sure.
And did you create statutes to create a single provider type? Because the complexities around all the rules that everybody has to follow create an administrative burden that is not appealing to people.
Right. So I had the pleasure of doing all that. That was my role. So it was fun. So we had all different types of accreditation. We were accredited by Joint Commission and CARF. And also we had state licensing. Each program, almost every program had a different license. So it was very complex. At that time, when we first built it, we didn't have parity. And so the state didn't even want any kind of sharing of anything. Like they didn't want the opiate, mainly the narcotic treatment program, which was the largest in the state, had like 600 people. They didn't want, like entrances couldn't be shared. And because of, it was really logistically, like we had to create different doors and so clinical flow and having the clinicians in the room as we were developing the building was critically important. And also that was also when integration started. So we also cross-trained against people's will, honestly. People, crisis people were like, we don't do substance abuse, we're behavioral health. And I'm sure all of y'all have dealt with this. Oh no, we're medical, we don't. But eventually, through a lot of change management and culture work and, really working on, understanding this is a whole person, and you guys, it's the same people. Honestly, like through data, we were able to show, and through our medical leadership, honestly, that the physicians who were really on board, they were able to really help with that and show, like, whether they walk in this door or this door, depending on what the issue is today, it's the same people. So it took time. I mean, it was hard. We had some people that couldn't get on board, and they moved on, and then we had new people that were coming in that were absolutely on board. So it was logistically difficult, but we got there. We had our sobering program didn't even have any guidelines yet. I mean, it was like the first of its kind. So relationship building with the state, and we came and we worked with them very closely, had them come, got them excited about it, asked for guidance while we were building it. They didn't have guidance, so we just worked together and licensed it one way and then learned from our mistakes and then licensed it a different way.
So one quick follow-up. So now is it not a conglomeration of silos that are co-located on a site?
No.
It's one.
It has different, I mean, it has to have, like, a narcotic treatment program has to have an NTP license, and it has many other. A crisis unit has to have a. There are some requirements that everybody has to follow, but the staff is cross-trained. They have, so like you can imagine our training requirements. So again, like we used an Excel sheet, all the training requirements, so we required everybody to have them because we had everybody work everywhere because financially that was most efficient. So, you know, for instance, my position was budgeted like 10% every single program. I mean, and that's how we did it. But it was hard, but it was fun. Okay, I think we're ready for lunch, and then after that, we're going to have Joe. Best part of the presentation. Thank you.
Thank you, Carla. So I'm going to ask for you to somehow, in a very organized way, make it through and help yourself to lunch. You have half an hour to get your food, sit down, so we can start Joe. He'll be speaking next. If you have not... No love, no love. All right, everyone, welcome back. Thank you so much for being expeditious in your meal consumption, and I hope you wash your hands. It was one of your 3 directives. So, what we'd like to do is to introduce and to also create a foundation for our next speaker. We want to show this short video, and then we'll go ahead and formally introduce him from there.
No one calls us to give us good news. They call us because something bad is happening, so they're in a crisis.
We used to have this thing in law enforcement. Ask it tell me. I ask you to do it, and I tell you to do it, and make you do it.
On average, in the police academy in this country, they spend 60 hours or more learning how to shoot a gun, and they spend 8 on mental health and communication. We need to shift that.
He is now feeling suicidal and homicidal. Your mom said that you haven't been on medication.
They found out he was trying to commit suicide.
Are you hearing voices right now? What are they saying to you?
Has anyone here, while you're in a work capacity, told someone, I'm scared? As human beings, we have to be connected. I don't want to land. It don't work.
Are you okay?
I promise you after that. You're not too broken, but you're fixable.
If it takes me all day long to convince them that we're not going to hurt them and they're going to come with us,
Hey, you okay?
I'll take all day long.
Oh, no, that's my partner, Joe. My name's Ernie.
So how many of you had a chance to see the documentary? Anybody? So a handful of you. Okay, so we invite you to watch that, but I'm going to go ahead and let Joe, our crisis cop from San Antonio Police Department, do his own introduction. He's got quite a story to tell. So if I could ask Joe if you could come on up, and we'd love to hear from you.
All right, how are we sounding? Can we hear me in the back? Beautiful. All right, first of all, I want to just take a moment to thank you for filling this room, for being here. It really is important, and I know I just got in last night at like 11:30, and so I'm really just late into the game and coming in what's happening here, but it really does excite me to see the mixture of people in this room, from law enforcement, from treatment providers, community stakeholders, local government, and it's super important. For years, my role in the police department back in San Antonio, when Leon was creating and Carla was creating the great system that we have through the Center for Healthcare Services, would be to provide what they called tours. And we would get people from all over the country that would come to San Antonio to tour the Center for Healthcare Services, to tour Haven for Hope. And a portion of the day would always be carved out for law enforcement. We would get 1 hour of the day anytime they would come. And so I've become used to speaking to outside agencies and outside communities and listening to what some of their needs are. And so this is an exciting experience for me to get to kind of come into your environment and speak to some of your needs that we're learning about. So I just wanted to quickly say thank you. Just a quick backdrop on me. I'm originally from just across the street in New York. I'm a proud Yankee from upstate New York. That's enough. And then I joined the Marine Corps right out of high school. So right when I joined the Marine Corps in 2000, obviously 9/11 happened. I was stationed out in California, and I did 2 combat tours. I got out in 2004, found myself in San Antonio, and in 2005 I joined the police department. So I've been with the San Antonio Police Department for the last 15 years. And then 4 years ago, I started doing some outside work and consulting, and now I'm very fortunate to get to work with Leon and Carla and their group to help them out. Because what we've learned along this time is, yes, laws are different. We know this. Yes, there are barriers to everything that seems to be good. We know that there are some people in the communities with very complex needs. But we have to remember that people are people are people. And what we're essentially doing is building systems that are built for us, right? Because if we know anything about mental illness or mental health, we have to first understand that mental health is a spectrum. Everybody in here is on that spectrum. We all have mental health. Some of us are very healthy, some of us are ill, but we all have mental health. And so when we're talking about collaboration and working together, we really have to be mindful of who is the population. Because it's not just them. It's not just systems that we're trying to create or programs that we're trying to create that's going to benefit them. It's programs that are going to benefit all of us. Because by the grace of God or whatever it is that we believe in, are we in a position that we're in right now and fortunate to be in this room. I stand before you with a diagnosed mental illness. I'm very open about that because I think it's very important. For those of you that have watched the movie, I talk about it in there. As a Marine Corps veteran, as a police officer in the 7th largest city, as a man, I feel like I have a responsibility to be unapologetically, authentically myself. And I can't expect people that I'm out there helping, that I'm trying to connect with, to be vulnerable or to open up and share their story with me if I'm not willing to do it myself. And so for me, I really do try and be who I am, where I am, and it doesn't matter who I'm talking to. So whether it's a room full of cops, or it's a room full of treatment providers, or it's a room full of kids at a high school, whatever the setting, it doesn't matter. I am who I am, we are who we are. The problem, oftentimes, is we get confused when we start to become what we do. And we live in a society where people are addicted to titles and positions and power and authority, and it creates barriers. It creates barriers to connect with other people when we are identified as or address ourselves as anything other than who we are, which is human. And I just think that it's important that we kind of set the slate for that. For me, so you know a little bit about, just again, where I'm coming from. I'm very, very passionate about this. I've been in the police department for 15 years, like I said. The last 10 and a half years have been full-time on the mental health unit. We've gotten a lot of publicity working with our stakeholders in Bexar County. We've gotten a lot of national media attention. We've got several different media outlets that have come and done stories. This filmmaker is actually out of Connecticut that heard the story that was written about us, came down, met with us, said, there's a story here, I want to tell it. Wrote 3 years. The movie took 3 years of filming, over 300 hours of footage, and condensed it down to 96 minutes. Unbelievable work by her team. Very fortunate that HBO picked it up. We got to tour all over the country in 2019 doing film festivals. The response has been incredible. People do not realize the epidemic that we're facing right now. And it's not just, again, it's not just the people that we're serving. It's not just homeless people, right? For the law enforcement officers in this room, we get it. 2019 was the worst year we've ever had in the history of our profession for suicides. 229 confirmed suicides, 4 to 1 versus the chances of being killed in the line of duty. The most dangerous part of our profession is ourselves, and our inability or unwillingness to say enough is enough, I need help. And so, again, it's important for me that we remove this idea, because when I do talks, again, law enforcement is what I do as a job. It's not who I am, right? That's not who I am as a person. It's a profession, because easy come, easy go. We all know, every one of us, that whatever position we have, whatever title we hold, the moment we separate, retire, die, the job goes on, life goes on, the position gets filled, right? So let's remember that we're human beings, not human doings, and make sure our priorities are in the right place. It's super important when we're talking about, again, creating systems, becoming uncomfortable, having conversations that maybe are going to be offensive to people. When we look at, again, I heard Carla mention it a lot this morning. And if you've ever talked to Leon, you've probably heard him say this, but you know, we are an overnight success in Bexar County. That took about 17 years. And so it's not that things have been easy. It's not that things have always been comfortable. And it certainly isn't that things are perfect, because they're not, right? We also are hurting just like you guys are hurting. We don't have enough resources like you guys don't have enough resources. The problems are the problems everywhere, right? Because again, there's just not enough federal funding support dollars being poured down into the communities that need it, or they're being kind of thrown in other areas. So, hold on, my thing moved on me here. I had some notes. Here we go. So when Ann was talking this morning and talking about inspiration, one of the words I love, right? So 2020, there's this thing going on about what's your word for the year. Mine is perspective. I think if we can learn to shift perspective and see things through a different lens, other than the lens that we've historically seen things through, just because it's always the one we've seen. It's always been done this way. This is why we do it this way. We become very resistant to change. And I get that it might be uncomfortable or uneasy for some, having some Texans come in and say, like, oh, these are the problems. And you're like, yeah, I get it, I know. But what does that do for us? Right? We have to be willing to not just identify the problems, but start talking about solutions. And when we become solution-oriented and we become solution-focused, again, maybe relationships can be developed that weren't before. I love the fact, again, that law enforcement is in this room right now. It's super important. Of all the groups that have come to San Antonio for us to do tours for, probably half of them did not have law enforcement representation. And it would be the first question on my mouth is, hey, well, great, we have city councilmen here, we have aldermen here, we have government here, you have a judge here. Great, you've got stakeholders. Where's the law enforcement rep? And they're like, we don't have them. We don't have a relationship with them. They're not on board yet. What I would say is already, just from the population that's in this room, you guys are doing really well and you're ahead of the game. Because at least there's a willingness to communicate, to collaborate, all right? One of the best things, and I don't just say this selfishly because I'm a police officer, one of the best things that the Center for Healthcare Services did under Leon, when they were building this, that what Carla was talking about at the Restoration Center, was they shifted their perspective from who are we serving? Yes, the end user ultimately is going to be the citizens that need it the most, and the consumers, as we refer them to sometimes. But who's the customer? Law enforcement. And when you think about law enforcement as your primary customer, it starts to shift a little bit of the perspective, because where are the people in the community? In the community, who's having to respond to them when the public calls because they're a nuisance, or they look different, or they're acting symptomatic based on their mental illness? Who are they calling? First responders. So then they show up, usually under-equipped, sometimes uneducated, without knowing what the hell they're supposed to do, because I don't know what this is, right? I don't know about schizoaffective disorder. I don't know about this type of bipolar. I don't know what to do when someone's non-compliant with their medications as a police officer. That was never supposed to be my function. But what we know is that a lot of societal failures and fallings fall on the shoulders of law enforcement because of a lack of education. And so people then will say, oh, it's a cop problem. Have the officers handle it. Have the officers handle it. And things just get thrown into our lap. And we do the best we can, but we have to make sure that our expectations are realistic. It's like if we understand trauma. Trauma is a language. And if we think about trauma as a language, right? A child developing A score after A score after A score, just one traumatic experience after another. A child growing up in an environment not suitable for anyone to grow up in, a lot of abuse, drug use, violence, incarceration, mental illness, all kinds of chaos, separation, abandonment, all these issues that we know of. How is it then fair that when they become 18 or 21 or 25, we just suddenly have an expectation that they're just going to have it figured out? That they're going to know how to find a job. They're going to know how to interview. They're going to know how to educate themselves. They're going to know where to go for resources. They're going to know that they're not supposed to commit crimes. They're going to know that, hey, all I've ever known my whole life growing up was that mom or dad was in and out of jail. Mom or dad was a drug user. Mom or dad was very, very resourceful in feeding the disease that they had. Why would it be any expectation that I should be any better or different? And sometimes we put unfair expectations on people that we're serving just because we're in a position of, well, I've done it. I'm a huge fan of the ACEs study. I teach it for our officers. I think it's super important that everyone understand that. Not only educating the public about the potential effects of children growing up in a traumatic environment, but also for us. All of us in this room that are responding to and dealing with people, do you know your own ACE score? And do you know how that affects how you think about other people? My ACE score is a 9. 9 out of 10. Terrible abuse starting at 7 years old. Ran away at 15. I had a terrible life growing up. I have a 9 out of 10 on the ACE score, but I don't use it as a, well, I've made it out, so what's wrong with you? Instead, I see it as a, hey, I've made it, and so can you. It's a very, very different perspective. When we don't look at ourselves as different than the people that we're helping or serving, we look at ourselves as just being more fortunate or further along in this journey of life. And really, that's how we should see it, is the people we're responding to are just at a different place on this journey. 100 years ago, they realized that the benefits of hygiene, right? So you're going to appreciate this, and you know this. But they were able to increase life expectancy 100% by learning the benefits of showering, right? Just simple, basic hygiene. They could double their life expectancy. That was just 100 years ago. So we learned the benefits of hygiene. Every one of you shower every day. I would imagine some of you twice. You probably 4 times. But we all shower because it's important, right? We understand the benefits of it. Not just, we don't do it from a mindset of, hey, if I shower today, I'm going to live longer. We do it because we understand it's a basic need, right? It's one of our basic functions or activities of daily living. We get that. It's no different when we're talking about inspiration, when we're talking about motivation, when we're talking about encouraging anything that needs consistency, right? The definition of wellness is something that is like consistently pursued. It's not just one time, right? We know, like, we're gonna do this gig today, we're gonna be here tomorrow, I get to meet with some officers tomorrow, super excited about, and then we leave. So then what, right? Everyone in this room has been to a conference. You go to the conference, you get filled with information, you're feeling all the feels, and you leave, and you go right back to doing the same exact thing that you were doing before. Why? Because change is hard. Because change requires buy-in. Because change requires other people, and then it's like, that seems like kind of a big hill, don't feel like climbing it today, let me just fall back into this habit. And if you know anything about the neuroscience or just people's brains and human behavior, we understand how habits are formed, and a lot of what we do and who we are is based on just conditioning. And so I just like to point out real quick, and this isn't like a downer of, oh shucks, but just if you think about life, we know we should be sleeping 8 hours a day. Should be. That's 1/3 of your life gone to a subconscious mindset. You're sleeping. 1/3 of your entire life gone to sleep. And then let's imagine you only work 8 hours a day. Some of you 10, some of you 12, some of you way too much. So that's another 1/3 of your life committed to career, school, profession, whatever it is. Then there's that 1/3 left. Half of that last 1/3 is made up of maintenance. Eating, sleeping, hygiene, all that stuff. So we have so little time that we actually have the ability to carve out time for us and who we are and what we want to do. We have to make sure that we're focusing on things that matter. And I would imagine everyone in this room, because the positions we're in, are hopefully thinking about what is our legacy. right? What do I want to leave behind? And we all care, or we wouldn't be here. If you really didn't care about, I don't care about what happens when I leave. I guarantee you, Leon, who's been gone from the center for years, still very much cares about what's happening in the center and what's happening in the system of care that he has helped create. Because it's a legacy, right? And we should be thinking about, how do I want to give back? What print do I want to leave once I'm gone from here? All right, let's breathe. Now I'll talk about specifics, right? That's a whole lot of fluff. But I want you to understand a little bit more about our system, why law enforcement's important when we're talking about the overall thing of what we're doing here. I've heard the word data numerous times this morning. Data, data, data. We have to understand data drives dollars. Oftentimes, we're not going to get any type of funds, we're not going to get any type of grants unless we have data, accurate data. Second to that is, I heard something a long time ago through one of our stakeholders that oversees a lot of this, and he said, transparency is the best disinfectant. I love it, because when you have hospital systems that are used to operating within their silo, and you have treatment providers, especially for-profit. We have several for-profit treatment providers in San Antonio. They don't want to show their books. They don't want to show what percentage of unfunded patients they're serving. They don't want to disclose any of that, because this is a business. This is a for-profit business, and I don't want to disclose any of my information. But when you have a room come together, and there's a little bit of pressure placed on people of like, well, hey, look, these people and these people are willing to show their cards, why aren't you? And furthermore, if you want to actually help the system, the overall system, if you want a seat at the table, you're gonna have to cooperate and participate. And it was very uncomfortable for a lot of people. Medical directors, CEOs were very resistant, I'll be honest. They were like, this is, and I'm just sitting there as an officer like, this is really fascinating to watch. Because what we know is, look, I get it, on the very, very just basic level, a police officer gets called to this call of a mentally ill person, and our primary function is, I want to just get this person as safely as quickly as possible and put them somewhere where they can get help. At least that should be the mindset. Still, sadly, in places, it's just arrest it. Arrest the problem away. I'm not going to deal with it. We don't have resources in our community that's going to support us. So why is it my job as a police officer to help anyone out? I'm just going to put them in jail. And we know that that's how the scales have tipped so heavily for jails and prisons to be the treatment centers that they are, the largest in the nation. So I think the pendulum has swung. Now there's all this jail diversion efforts that have been going on. So how do we swing the pendulum back a little bit so we can get a little more neutralized to where people who need treatment can be in treatment facilities, and people, to your point earlier, sir, who had that question, if you're committing crimes and doing acts of violence, then obviously, yes, you need to be in an incarcerated setting, but still receiving treatment if you need treatment. And that's a whole separate issue, right? It's just because you have committed a crime, even if you are seriously mentally ill, it doesn't mean that your mental health needs should be neglected just because you're in jail. But having those difficult conversations where hospitals will come together, realize how are we going to fund this. We have created several programs that we're super proud of just in the last year and a half, 2 years. Two of them that I'll share with you. One of them is called Law Enforcement Navigator. So, más o menos, more or less, we have in San Antonio about 15 to 16 physical locations that we can take a patient off the street and bring them to one of those locations, whether it's an ER, but with psychiatric intake, or it's a standalone facility, or it's a clinic, whatever it is. We have about 15 options that we can go to. What happened though is 2010 and earlier, on average, our police department was doing about 200 emergency detentions or involuntary commitments per month. We were doing about 200 a month. That was pre 100% 40-hour CIT training. The chief then mandated every officer in this department, 2,300 of us, are going to go through 40 hours of CIT. What do you think that did with the numbers? Hockey stick. We now average 1,200 EDs a month. Emergency detentions, involuntary commitments, 1,200 a month. So here's what also happened. The hospitals, who used to be our biggest advocates, and they would show up at our training and feed us and give us food and snacks and say, bring us your patients, we love you, we support law enforcement, here's a computer, a printer, a cookie, a drink, come on in, bring us your people. Now, at 1,200, they're like, get out of my hospital. Why do you keep showing up? We're full, we're at capacity. We have patients on the wall. We cannot take anymore. Quit coming here. We don't want, and now we've got this. And now the hospitals suddenly are mad at the law enforcement officers thinking, we're the problem. What are we supposed to do with them? So Navigator was born. This group called STRAC, they looked at it. What they used to do is they would look at air life, and for like a 50 county region, if there was a major vehicle accident or something terrible happened and they had to use air life, they would decide, basically dispatch, where the air life was gonna go to which trauma center. Then they started tracking EMS. We have city EMS, another department, so they would track them. Where are they going to? How long are they being walled? When they show up, what's their time in and out? They started tracking that. So then because there was complaints, they said, hey, look, we'll look at this. We'll do 6 months of looking at data of where the emergency detentions are going, where cops are bringing the patients, because all the hospitals are saying, you're bringing them all here. We're getting all of them. We're getting all of them. We're getting all of them. Transparency is the best disinfectant. He puts up the slide and was like, actually, this hospital, who you're the most outspoken, you're getting about 4%. So like, let's breathe. You, who obviously are also complaining, you have a legitimate complaint because you're getting a disproportionate amount. You're getting like 87% of the emergency attentions. Why? And it was because their capacity made no sense. They had individual like plexiglass. It's not as inhumane as it sounds. It was a very nice facility, but there was individual bays where they could be locked in and monitored. The nursing station was like in the middle, and they could see patients all through the whole place. But they were secured. In these just regular ERs, they have curtains, right? And then it's a staffing nightmare if they have to be on a one-to-one. And so then what do we do with them? And I can't, you know, what's the rules on sedation? Are we allowed to medicate pre-consent before they're admitted? So there's all these barriers that we had to learn about, but getting the people to the table to communicate their needs, their frustrations, super, super important. The hospitals, so this program Navigator, the hospitals actually funded it. They threw up a couple $1 million and said, let's see what happens. So what it is that there's an actual dispatcher out of that STRAC building. It's not the police dispatcher, it's not at our communication center. And they have a clinician from the Center for Healthcare Services, and they're actually managing all the beds in the city. They're all online. They have a computer screen up and it shows green light, green light, green light, this hospital's red, they're on diversion. And we know which hospitals are open, who has capacity, which hospital's on diversion. Then, anytime we have a behavioral patient in the back of our car, we call dispatch 24/7. Based on geographic location, they will then send us the nearest appropriate inpatient mental health facility, which also, by the way, puts us in compliance with the Health and Safety Code, which says verbatim that our responsibility is to take custody of them, detain them, and then transport them to the nearest appropriate inpatient mental health facility or mental health facility deemed suitable by the local mental health authority. So, historically what we were doing, because we're cops and we're resourceful, creative, or lazy, is I'm just gonna take this patient to the closest hospital. I don't care that it doesn't meet their needs. I don't care that they don't have psych there. I don't care that it's gonna delay their treatment. It's convenient for me, it's in my district, that's where I'm gonna go. And so, again, it was cost prohibitive. It was delaying the person's actual time before they were getting care. And so now with Navigator, again, call the dispatch, they know where we're at. They say, hey, look, this hospital has a bed, go to that facility. Roger, we hang up. They then call the hospital. And they say, hey, you've got PD en route, they're gonna be there in 12 minutes with this patient. You can expect them, this is what's going on. Beautiful. We show up, they're expecting us, we're in, we hand off the patient paperwork, and we're gone. 15 minutes or under. And now there's no wrong door. Now we're not bringing people to the wrong locations because it's what's best for us. But that program was birthed out of collaboration and complaint and realizing a need. The second one I want to talk about is PIC. And this is, the acronym is Program for Intensive Care Coordination. So what they did is they looked at the top 100 utilizers of people utilizing services in San Antonio, the top 100. Each one of these people is costing at least $1 million a year to the public safety net of acute care, doc shopping, med seeking, going to every ER in the city and beyond. Some of them were getting emergency detained 4 or 5 times a week. Hospitals knew them. As soon as they showed up, they're like, oh, no. Or God forbid that it was a substance use issue, right? Because we have a huge problem with meth in San Antonio. So now as soon as you show up and your UA reveals that you're on meth, they're gonna quickly get you off the meth, stabilize you, have you sign a safety release and get you out of there. Which means that the mental health issue never actually even gets treated, never even gets touched. And so we've got this revolving door, right? It's a huge problem, which is why our numbers are so high on the people that we're seeing, because there is such a huge problem with substance-related psychosis. And the officers are making their best decision in the field of like, oh, you're actively psychotic, what you're doing is really, really erratic, you're a danger to yourself, I'm gonna take you to the hospital. The hospital does UA, sees it's meth, and they're like, I don't got time for it, and they let them go. And then here we go again. So what PIC does is they took 2 officers from our unit, the mental health unit. We have 2 mental health officers, we have 1 full-time licensed clinician, and we have 1 MIH paramedic, which is mobile integrated health paramedic, 4 of us. And those top 100 people, we said, instead of us sitting around waiting for you to call 911, which we know is gonna happen, we're gonna show up at your door. And we're gonna show up at your door a lot. Because what we also know is that some of the people with the most complex or highest needs are very lonely. People with serious mental illness oftentimes have been isolated from their family, from their social support groups. They don't have friends, and so they're alone oftentimes. And a lot of them would call to go to the hospital just because it was a social setting for them, and they enjoyed it. And so we said, it's a huge burden financially on the city, on the taxpayers, on law enforcement, on EMS. We've got to be able to do something different. So building those relationships, now they show up weekly. We have a psychiatrist at the center, so like you don't have to wait 3 months to see a doc. We're gonna bring in one today if you wanna see one today. You need meds, let's go get meds. We've got money in the budget. You need help buying your meds, we're gonna help buy your meds. We'll give you a 30-day supply. You need food, we'll set you up food. You need, what do you need? And a lot of times these people qualify for benefits that they have no idea about. They qualify for things they have no idea about. They qualify for SSDI, they qualify for Social Security, they qualify for veterans benefits. And they have no idea because, again, it's intimidating to approach some of those systems. And how can I fill out all these forms required of me to get whatever it is I need? Sometimes it's simply just holding the hand and walking them through the process. And so we have to have people in places that are willing to, which is why, are we familiar with the, I saw Carla had it up there, the mapping, but the sequential intercept model? Do we know about the sequential intercept model? Again, PRA put it out, you can look it up, it's free, it's online. The policy research analysts, I think, I don't know. But the sequential intercept model is just it's a mapping that any community can use. So it starts at 0 and then it goes 1 through 5. So they have crisis line at 0, like a hotline at 0, dispatches at 0, and then you've got law enforcement at 1, and then the jails, and then the courts, and then care management, all this stuff. So it spells it out for you. But don't just look at that and think like, oh, okay, that's cool. What you should really do is have this like committee on subcommittee, and this is what we've done. And we would have meetings to then have another meeting, to get on a board and write them out. Like, where are we most likely to interact with people? Where are we seeing the highest population of people? Where are we going to intervene with them? Put it on the map. And then, where are our resources? Does it make sense? We have a lot of resources here, but people are never getting to here. So it's just a guide to use, like a template to use to figure out where we are and how successful we're becoming when you start to kind of lay it over the top, like tracing paper, and realize like, wow, we are way off. Like our lines are not even close. Because yes, I hear there's some great systems here. I hear there's great programming here. That's awesome. But if we have incredible programs and we have an incredible problem, then where's the disconnect, right? So how do we then find that gap? And again, that's not like a call out to anyone, because personally that's one of those things for me too, where within our profession, I cannot figure out why we have more resources than ever before for law enforcement, specific for law enforcement, and yet our suicide numbers continue to just stagger and go through the roof. Why? And so it's the same for us. Like, we have to identify what's happening to get people from where they are to where they need to be, and what is that gap, and how do we kind of bridge that gap. I know CIT was up there, right? for the officers in the room, are we all CIT trained, 40 hours or no? I don't, is there a state mandate in New Hampshire of CIT training or no? No. So for me, it's one of these fascinating things that exist in the world of, I get it, like I get it. It was never meant to be. Is there any NAMI folks in here? So we're very close with NAMI. We have a great relationship with our local NAMI chapter. But there are some people in NAMI who are like, hey, we don't want law enforcement involved with anything to do with mental health or mental illness. Okay, that's an opinion and a belief, fair enough. But, and then there are plenty of law enforcement chiefs, executives, senior leaders that are like, yeah, we don't want anything to do with mental health problem at all either. So like, there you go. But is that realistic? In the state that we're in right now today, in the current climate of our country, is that realistic? No, we don't have a choice of what we respond to. For me, and this is one of the big rubs with the Memphis model of CIT. CIT's been around since 1988, right? Started in Memphis, Tennessee, 40 hours of training preparing law enforcement, first responders, how to deal with the mentally ill. It's been around for a long time. But one of the things, and I've had the discussions with them, so I'm not telling you any secrets, I wouldn't say if they were here. But one of the problems that I have is that their model is that you only train 10 to 20% of every agency, and that it's only voluntary based, because CIT is not for everybody, and that's their belief. Now, here's my problem with that, because San Antonio is one of the first, it was the first major city, but it was one of the first to mandate 100% across the board, and that's 2,300 officers. And they're not a fan of it. They're not a fan of the movie because they show us teaching 40 hours of cadets, 40 hours of CIT to the cadets. And they don't feel like cadets should get mental health training. It blows my mind that we understand law enforcement is going to be the people, are going to be the people to respond to these situations, but we're going to be picky and choosy about what training they have or don't have. And I don't know how it is here, but never in my 15 years of being a cop have I been dispatched to a call and I'm like, nah, disregard, I don't like that one, give me the next one. Nah, next one, I don't want that one either. That one sounds like it has a mental health component, skip, I want the next one. We don't have that luxury. So why then do we have the luxury of being trained or not trained? Like why then do we have the luxury of saying like, nah, mental health's not for me? Saying mental health is not for you is saying that you probably shouldn't be in the law enforcement profession. Honest to God. We should not be in this profession if you're of the mindset of, that is not a problem I'm willing to or wanting to face. Because I believe that 90+% of every single call we respond to is some form of an emotional disturbance or crisis. Even if they don't have a diagnosis, they're in an emotional disturbance. Because how many times have you in this room called 911 to your house because your spouse yelled at you or hit you, or your kid won't wake up in the morning and go to school, or because you're mad at the neighbor, or because you're symptomatic of your mental illness, or because of whatever other millionth reason why people call police? It's not because everything is well, right? We have to understand that. So we have to understand that CIT is just, and for me, again, put me in charge of all the things, which would be scary and beautiful, but 40 hours for a cadet is still not enough. 40 hours for an officer is still not enough. That's a great, great introduction. But we need to shift the focus. We need to shift the emphasis on how we're training from, again, even just, for me, again, personal, but how are we training cops? How are we preparing them? Are we preparing them for this great battle that maybe one day might happen in your 20, 30-year career, but most likely will never happen? Or are we preparing them for self-care? How to identify problems within myself so that I can help other people? Because there's no way we can effectively help or serve anybody if we're not willing to effectively or serve or see ourselves, right? And we know that. You can put on a show for a good period of time, but that gets overwhelming. And we know what the implosion looks like. And that's why we all struggle. Same thing with nurses, doctors, you guys get it. We're people facing. We are people facing. And moral injury is a real thing. I don't believe in compassion fatigue. I don't believe in burnout. I think that blames the victim 100%. It's like saying it's your fault. Well, no one told you to be a nurse. Well, no one told you to be a doctor. No one told you to be an officer. Nobody told you to be a paramedic or a firefighter. You got into this. So suck it up that you're dealing with all this stress and problem. We have to be willing to see it different. We have to be willing to shift the perspective of, yeah, I came into this with great intentions. I went through nursing school. I went through school, a lot of school to get my MD. I went through a police academy to get my badge and earn the right that I have. Why then is it not okay that suddenly my intentions, which were really, really good, I want to help people, I want to serve people, I want to do all the right things, and then year 1 comes, year 5 comes, year 10 comes, and suddenly you hate everybody. You hate people, right? We're completely desensitized, we're callous, we're jaded, we're negative, we're frustrated, because the systems, honestly, is what happens is that we get swallowed up in the systems. And these systems, especially ineffective systems, overwhelm us, and they frustrate us. And it's like, yeah, I care about the job I do, but what does it matter? Like, if I'm gonna show up to someone's house and de-escalate them and not use force on them, but then the end outcome is I'm gonna take them to jail because I don't have a treatment facility, that's frustrating. Or I'm gonna take them to an ER that doesn't have site capacity within the ER, and they're gonna release them in 2 hours, and they're gonna be right back out, and that happens times 100, times 500, times all the time, and you're like, what's the point of any of this anymore? And we start to lose hope. And that's a dangerous place to be. Right? So we have to remember why we got into this in the first place. It's super important. For the officers, I tell them, I wish I could record your interview panel before you ever got the job. Of like, why do you want to do this? And they say all the most beautiful things. They read all the billboards. They quote the saying on the car, right? And their intentions are good. And then I think at 5 years, we should be forced to watch it. Like, hey, look at this. This was you saying that. What? I said that? Because we deal with people, and people can be difficult, right? And so we just have to remember, why did we get here in the first place? We have national model programs. We have gold standards per White House under the Obama administration. We have beautiful things happening in San Antonio because of great leadership, like Leon and Carla. We are very, very fortunate. Also, when it comes to funding from federal dollars, we're consistently in the very, very bottom, right? Sometimes 49th. So even without support of federal funding, we can still make it work. Why? Because we have people that are willing to come forward to sit at the table and say, hey, I'm willing to embrace some of this as well. And suddenly, our private care facilities that we found out through transparency, their rate of accepting unfunded patients was about 9%. That was their due diligence to the community. Like, we're gonna serve the underserved, we'll do 9%. Since they've joined in our programs and they're at the table, they're around 35 to 40% of their population is unfunded. That's not good for business, but you know what? They keep showing up. They keep showing up because they understand that if they pull out, it's much, much different to have to market for business when you're trying to get people in your doors if you don't have law enforcement bringing them. Because again, 1,200 people a month are in the back of our cars. Where are they gonna go? And if you want to pull out from us, then you're gonna have to try and fill whatever percentage of the population on your own. That's a whole different marketing budget. What the hell, let's just eat it. We'll do our 30 to 40%. Again, it's not perfect, but you have to have people that are willing to hurt collectively, because this is a huge problem that we're not gonna address by sitting around looking at it, that we're not gonna fix by just talking about gap after gap after problem. Like, we address it by truly coming together and saying, hey, look, this is what we do, this is what we have, this is what we need. This is what we do, this is what we have, this is what we need. And then after all those things happen, again, write it out. It doesn't have to be technologically advanced. Just write it out. And everyone can look at it and just, wow, okay, here's an opportunity. Here's an opportunity. Every time, I don't know if you caught this or not, but every time Carla could have used the word problem or issue or failure or this or that, she used the word opportunity, because that's a perspective shift. That's how we see things, right? We don't see failure, we see an opportunity for growth. We don't see failure as like, not worth it, like just get rid of it, shut it down. There's an opportunity for growth. And so don't get frustrated by things not working out or not being quick. We are still, that PIC program I just told you about, which by the way, they tracked the first 67 people that they were able to monitor. Just over a 3-month period, I'm sorry, 47. The first 47 people that they tracked over the first 3 months of that program, there was a 67% reduction in 911 calls. Compute that to response times, to officers' times, to EMS times, to transports, to hospitals. That's a huge cost savings. 67% reduction just in those 47 people, which were, like she pointed out, that 5%. Most of the money, most of the resources goes to the smallest percentage of the people with the highest care of needs. And so if we can reduce those numbers, by collaboration, by understanding what the problems are, and who can really address them most effectively, then why not? I was supposed to go at 1:30. I just looked at my watch, it's 1:31. I can't even make this up. That was beautiful. Now, I know that we are going to transition into like a 30-minute Q&A. And so I would love to answer or entertain any questions or statements that anyone has. And then if there's anything also for Carla and the team, they can also answer out. So anything from me, law enforcement related, not law enforcement related. Sir?
The STRAC system you were talking about, navigators, where does that live? Is that in the 911 system?
No. So STRAC stands for the South Texas Regional Advisory Council. So it's a separate entity. They're not funded by us. They're not, which is important, right? Because when you're thinking about, even if you're just thinking about optics, who is going to manage all the data, which is why Carla referenced that as well. So you don't want one of the treatment providers saying like, we got it from here. Like, we'll monitor all the data, just bring it to us. You really should have a removed party looking at things to just keep it even and fair. And so again, their function was really just for EMS and midlife. It was medical only. And then because the behavioral problem is what it is, they were like, hey, we'll look at it, we'll track it, because we have no interest. I could care less.
Dispatch piecework, because that's going to be in real time.
So on our dispatchers, which is totally separate from that, and by the way, we also train our dispatchers in CIT. They get 16 hours of CIT that we provide. We also train our fire EMS with our officers. So it's super important. If our CIT school has 70 people in one class, probably 30 of them are paramedics and fire. And so it's about, I'm not a mathematician, but it's about 40% is always going to be fire EMS, because it's super important that they have the same training we have, because they're going to the same calls we have. Additionally, for dispatchers, historically it was quick, right? Police, fire, EMS, their average call time was like 22 seconds. Police, fire, EMS, what's the address, what's chief complaint, they're on the way. Boom, send it out, gets dispatched. We were like, we have got to get away from this, because it's a safety issue for the officers first, but we can do better than that. So now we force them to try and stay on the phone for 2 minutes, at least, and ask more appropriate questions. So now when we get a key card, when we get the information before our dispatch call, it has diagnosis, it has medications, it has breathing pattern, it has drugs, it has weapons, it has like all this stuff that they already asked. Now again, are they 100% honest all the time? Maybe not, but at least gives us a little bit of headway when we're showing up, knowing like, okay, I'm responding to someone who admitted to having a mental illness. They're saying that there's drugs involved. I already have my mindset of what could possibly happen. I need to make sure I'm adjusting it. It's important that we train dispatchers. Really, so one of the things that, one of the reasons why we've had the success we've had is because we've taken CIT and said, how can we put this into everybody's world? We do 2 schools a year called CCIT, which is Children's Crisis Intervention. Still 40 hours, and it's all the school resource officers, school administrators, counselors, same thing. And we make the officers and the counselors do role plays together so that they're on the same page. So because of our mapping, because of our meetings, because we understood, we said, hey, where are we most likely? One of the things for me, when you look at the sequential intercept model, it starts at 0. There was talks, and I don't know if it went through or not, but there was a talks of like -1. That's where I want to live. Education is huge. We should really be looking at, because all this, everything we're talking about right now is reactive to a problem that already exists, right? Everything we talk about is reactive to a problem that exists. Everything that we do in this society is reactive. Now schools are doing active shooter drills, right? It's reactive. We did the fire drills because there was a school fire and kids died back in the 50s. Stop, drop, and roll. We all remember that. Now it's school shooter drills because times have changed. We have to make sure that we're willing to stay on top of change, be willing to change, and understand when change is around us. If we're doing the same thing today that we were doing last year and 5 years ago, it's a problem, right? We have to be willing to kind of expand and get uncomfortable. And one of the best things that we can do is realize that in our discomfort is oftentimes the best opportunity for the most successful outcomes. But we have to be willing to get uncomfortable. Does that answer your question?
Yeah.
Okay. Anything else? Yes, ma'am.
Does Texas have a 211, and if so, how do you work with them?
So we have a 311.
Okay.
And Not really at all.
Okay.
Yeah, so it really is its own separate thing. And there's no cross-training, in my 15 years of law enforcement, I've never told someone about it, I've never referenced it, I've never even, I mean, I know of it, but no one's ever talked to me about it. So there's no, that I'm aware of anyway, I haven't seen anything related to that. So,
You were talking about the ACEs. Do you ever incorporate that into training with police officers?
Yes.
or-
yes, so I made ACES part of our 40-hour CFT curriculum, and then I teach in-service every Tuesday at our academy. And so it's also a class that I'm teaching for there. I also will give it in schools anytime I do speeches or talks. And then when I go to calls, if there's children in the home, I give the family, whoever's there, the website just as a resource, and I say, hey, when I leave here, this is what I would like you to do. I want you to take this test for you, but I also want you to think about how you're impacting this child. But from a law enforcement standpoint, I think it's super important that we understand when we show up on scene, if there's kids involved, how we can contribute to that child developing an ACE score, or how we can potentially mitigate by how we respond, how we treat. Again, if you have to make an arrest, make an arrest, but understanding that having your parent arrested is one of the scores, can we do this with some grace, right? If we have rapport, which should be the goal, if we're connected, and I say, hey, look, sir, you gotta go to jail because of whatever, I have to take you, I don't want to do it in front of the kids, right? Let's go outside, let's whatever. Again, don't think like, that's gonna work every time. I get that there are people out there that have bad intentions and will run away or fight you or whatever. I'm not ignorant to it. But I also know that in our world, I can tell you that in my almost 11 years of doing full-time mental health in San Antonio, dealing with some of the most psychotic people we have, with guns, with knives, on bridges, on buildings, I don't have one use of force incident, not one. Never tased, never pepper sprayed, never baton, never punched, never nothing. Dealing with thousands of very, very sick people. Why? Because my priority is connection, it's not correction, and my priority is seeing the person, not the problem. And I've learned to look through a very different lens than a lot of officers. I'm not here focused on the problem, I'm here focused on the person. I don't care that you're screaming and yelling and saying F you and die and all this stuff. What I'm really hearing you say is you're really sad and you're having a bad day. Learning how to see, learning how to listen, learning how to shift the way we perceive things, because it would be very easy for me, for those of you that watched the TED Talk I did a couple years ago, I said this, I've been hit, I've been slapped, I've been pushed, I've had food thrown at me while I'm on duty, all of which are a felony charge, assault on a peace officer. I haven't arrested any of them. Why? Because their intention wasn't to hurt me. Their intention was to communicate with me that I don't agree with you, that I'm as sick as you say I am, and I'm not ready to get help today. But I have no choice. You meet the criteria, per the guidelines, I have to take you. You have to go to the hospital. And I would be very frustrated if I was in your situation too. So why get mad at it, right? Why get mad? You're not pushing me to hurt me, you're pushing me because you're frustrated. I get you're communicating that you don't want to go, and you're trying to hold on to a little bit of dignity. We just have to be willing, right? Because again, sometimes we're very, very proud of ourselves, and we don't like to be called names, and we wear these fleshy suits that sometimes get our feelings hurt. And when someone tells us something, we're like, oh, please don't say that to me, it's so mean. Or we get really mad, and we want to fight, we want to resist, we want to push back. Pay attention to the intention behind what's being said, not the words that are being said, right? Which is why training is super important. In understanding basic elements of human behavior, understanding effective communication, understanding the power of active listening, understanding how all of those elements go into making for a good officer who's willing to take the time to express empathy and compassion and care to get the desired outcome. I can get someone to do almost anything I want them to do, and I don't have to force them to do it. I probably handcuffed 5 people in 11 years, and most of those were at their request, because they said, I don't trust myself, I don't want to do anything, please handcuff me. The rest of them, as violently angry outbursts as they were, I talked them all into the car, walking on their own without cuffs, because I treated them with dignity. And that's so simple. Also, we wear plain clothes. That helps, right? Because I have a belief that if you're an adult living in this country, it doesn't matter where, this isn't a New Hampshire thing, it's not a Texas thing. If you're an adult living in this country with a serious mental illness, you've probably had a negative interaction with law enforcement at some point in your life. That's my personal opinion, okay? So knowing that, How then do I then combat that? How then do I get over that barrier if that's possible? I want to make sure you have a better outcome this time than maybe you had one before, or you saw your family member go through. Maybe it wasn't good. Again, I'm not blaming cops. We can't expect them to be mental health experts if they've never even been through CIT. We can't expect them to be behavioral health experts if all they know is criminal law or civil law. And that's it. And like just elements, culpable mental states, probable cause, that's all they know. You throw mental health, they're like, holy hell, what do I do with this? I don't know this one. And like spoiler alert, especially cops in uniform, we do not like to look stupid, feel dumb, or feel uneducated about something. So we'll tend to rah-rah act out, and sometimes our responses are based on the fact that I don't understand what I'm seeing or facing. And so it's easy to use force, because I've been trained that, I've been taught that. So if I don't know what's happening and you're symptomatic and you're mentally ill, it's very easy to go use force, because I don't know how I'm supposed to communicate well and just be gentle and patient. I don't know about that, because that's not what's trained most times. I had a cadet just 2 weeks ago when I was training our cadets ask me after one of the role plays, he said, hey sir, I didn't want to ask during the role play, but are we allowed to apologize to people? Blows my mind, right? It blows my mind the perceptions that people, like, yes, that you're still a human being. But again, our profession, unlike most others, we get lost, we forget sometimes, because it's, again, we put on the uniform, it's like, us versus them. I am this, right? The whole thin blue line thing. We have to be willing to like be human, regardless of what outfit you're wearing. Right? We have to be willing to be human and just treat people like people, and you're going to get better outcomes. What else?
Chuck.
Sir.
Why don't you talk about the system that was designed where officers can support other officers that have gone through stress, that need help, and so they can maintain their dignity and their anonymity.
Yeah, so that now is my job. So since the movie ended, since Ernie and Joe ended, Ernie and Joe are no longer partners, which was super fascinating when we were doing these film festivals, and people were like actually crying about it. And I was like, relax, it's all good. Very concerned about what's happening. But no, so Ernie works on that PIC program. He actually helped kind of get it up and going. He's running with it full time. He's one of the two on PIC. My job now, 100%, has become internal. So all I'm doing now is officer-related issues, officer wellness. I'm getting our own officers into treatment. I'm getting our own officers into therapy if needed. I'm giving our own officers resources because it's important. We have done a great job in San Antonio preparing our officers to face and serve the community. We've done a great job. Some of the, byproduct benefits of a good CIT program, and we measure this, is a significant reduction in use of force, a significant reduction in complaints. It makes for a better police department. It's smarter. It's a smarter way to do business. So those are just products of it. But I said, hey, we have done a terrible job taking care of us. We prepare officers all day long to like, hey, you're going to do this and talk like this and listen like this and do this, and these are the resources and this is all great, and they're helping people all day long. And they have no way of dealing with their own stuff because they have no clue how to do it. I was at NYPD a couple months ago, and Dr. John Mann out of Columbia, they did this longitudinal study, and he said on average, a police officer responds to 188 traumatic events in 20 years, in a 20-year career, whereas your average citizen responds to 0. We should have no expectation that officers are just going to be okay. We were never meant to see and experience the level of trauma that we see and experience. The problem is, just like in the healthcare profession, people show up in your ERs, you're used to, you're surrounded by significant pain, emotional pain, physical pain, injuries, ailments, all these things. We become so desensitized to it that it puts ourselves at greater risk because our threshold gets so far expanded that suddenly we think we can handle a lot more than we can. But also, because I'm in the helping profession, I can't go get help. That goes against everything, like I am the helper. So then here's where we see maladaptive coping strategies, right? Alcohol, pills, opiates, porn, terrible relationships, whatever it is that we become addicted to as a byproduct to numb out from having to deal with our stress. Cops are absolutely terrible at advocating for themselves and saying like, hey, I need help. I need, which is why I share my story, right? I have 2 therapists, one through the VA and 1 marriage counselor, just because it's important for maintenance. Because by 34, I had 3 divorces, 4 kids, paid $3 grand a month in child support. Like, I was a mess, rock bottom, been suicidal since I was 15. Like, I don't take it lightly. And so for me, it's like, I knew I got to a point where I was like, I can't, but I was on the mental health unit. Compare and despair, right? It's very, very easy to tell people what your problems are. Oh, man, you just need to do this. Just go here, it's gonna be better. Just go do this. I wasn't willing to do it because I wasn't willing to be seen, right? I wasn't willing to be seen. And then eventually I got to a place where I was like, I've got nowhere else to go. It's either I'm gonna take myself out or I need to get help. And I got help. And that was 3 years ago. I go every month now. The VA has been incredible for me. They put me on this like alpha stim thing, like you put it on your earlobes and it supposedly manipulates your alpha waves. Regardless, it's beautiful. I like it. But so a lot of my experience, a lot of what I speak on is not just learned experience, it's lived experience also. And so I know that there's a significant hurt right now within the law enforcement profession. There is an epidemic right now with officers, and there's a gap, right? Because it's scary. For police chiefs, for senior leaders who have been doing this job for 25 or 30 years, they have convinced themselves that like, I've made it, why can't you? And we have this stigma, which is, weakness or soft. And so when I'm teaching cops, and I was just there Tuesday, today's Thursday, 2 days ago, I was at our academy in front of 60 San Antonio police officers, and I give them a survey, because I want to know who's in the audience, and it's anonymous, but I put on there, male, female, time on the department, and then like a section or like where they work, chief's office, patrol, whatever it is, vague. And then there's 5 questions. A lot of them 25 plus years. But when I say, when you hear or think of the word therapy, or if you needed to go to therapy, what would that mean? And a lot of them feel like it means I'm not cut up for this job and I'm weak. That's a problem. When we think of the word toughness, cops, right? Tough, they're tough. They're tough. Male, female, they're tough. That's a tough profession. Toughness. We lie to ourselves, right? Tough isn't swallowing it. Tough isn't suppressing it. Tough isn't compartmentalizing it. Tough is saying, I need help. Tough is saying, like, enough is enough. Like, I need somebody to please help me get through this. Oh, and by the way, I would love it if I had an administration that would then support me. And not be like, oh, you're having a bad day? Like, oh, you're contemplating suicide? Give me your gun, give me your badge. Go sit in timeout for a few months. We're going to figure out how to get rid of you now, which happens, right? And it's unfortunate because then it's like, yeah, why would you ever expect them to come forward? Cops aren't going to come forward if they know that there's a consequence. We shouldn't be focused on sanctioned behavior. We should be focused on supporting people who are in need, including us, right? And so we're very fortunate. Again, our chief, we have full autonomy. We have an officer in need. He's like, I don't care what it is. If they haven't violated any like real laws and no one knows about it, the public's not upset about anything, get him help, whatever it needs. I have 2 officers right now with 42-day inpatient stay. As soon as they're done, they come back to work. They do a fitness for duty, see a doc, all is good. We've been doing it for years. I've got 2 more officers in alcohol outpatient treatment right now going on. I've got several officers in therapy. Like, we have officers finally coming forward. But every time, it's the first time because they think like, oh my goodness, everyone's going to find out. No one else has ever been through this before because we operate under confidentiality. And so then we have to just do this whole thing over and over, like, no, I promise you, like, you're number 40,000, like, just relax, we've been through this before. But they don't know, right? Because we don't tell our success because it's no one's business, So if they want to share their story, that's on them, which I believe in. As you can probably tell by now, I'm a huge believer that every single one of us has a story. But not every single one of us is willing to share our story, our honest story. And even if, and I've heard this before too, it's like, well, Joe, I don't have childhood trauma. And I'm 40 and my parents are still together today. And we still have family dinner on Sundays. And my mother still reads to me at night when I go to bed. But they've had this like picturesque storybook life. Guess what? They still have a story, right? There's nothing, it's like for some reason we feel bad if we don't have some form of trauma because it's like, I don't have a good story. Like, my story is terrible. I hate it, but it is what it is. It's what I do with it. good for you if you have a great life. You still have a story. We have to be willing to share it, because I think, honestly, my belief is in our willingness to share our stories is we will be more focused on our similarities than if we put our representative selves into the world only, and people only get to see our representative selves. It's very easy to see differences, right? It's very easy to see differences because, yes, you got up on time, you got dressed, you all showered, you look great, you came here today. But I know, just based on population, just based on percentages, people in this room right now are struggling. People in this room right now are scared. People in this room right now are depressed. People in this room right now are going through trials, relationship issues, suicidal ideations. I know it, it's a fact, guaranteed. But yet we show up, we smile, we handshake, oh, that's good, yeah. And then we leave like, Jesus, I hate my life. And we don't know what to do with it because we're afraid, right? So we have to be willing to take off our masks. We have to be willing to take off our masks, especially in what I would call a safe space, like this, with 128 mixed people, right? And if I can do it, and I am safe, like no one's hurt me, no one said anything, you might be thinking terrible thoughts about me, but that's cool, I forgive you already. But we just have to be willing to do it together, right? Because again, for me, self-care is individual specific, it's not profession specific. What else? Questions by anything? For Carla? For anything? We're good? All right, so if you'd be willing to just do a quick exercise with me, this is just to gauge how well you've listened. All right, so it's very simple. Just gets us to move a little bit. It's after lunch. So just put your hands out in front of you like this. Very easy. No tricks, no gimmicks. Okay, turn the hands down like this. We're going to go right hand over left hand, interlock your fingers. Just like that. All right, now, look at your pinkies. Some of you have left pinky on top. Some of you have right pinky on top. So how you got your left one. Yeah, so how you hold your pinkies? That just, figure it out. It says something about you. I'm not going to tell you what it means. Do exactly what I do on the count of 3. No tricks. 1, 2, 3. So, Mayor, we've identified another gap. Listening is a problem in this room. Simple? No. It's ridiculous. I just like to have fun. It's very easy to manipulate the mind. I am a neuro geek, and so it's fun for me to play with you guys. So anyway, thank you guys. I appreciate your attention. I really, really appreciate your attention and giving me an opportunity to speak to you today. So thank you.
We are going to make sure that we get out slides to you and contact information. For those of you who are in Manchester, you're going to be getting an invite again for our next Emergency Operations Center meeting so we can reconvene and also follow up from the week that we've had for our visitors. I want to thank all of you from San Antonio and Bexar County, not Bexar County, for coming out to Manchester, and for all of our visitors from around the state. We thank you for what you do every day and for taking the time to be part of our community for this one luncheon, and we hope we can do more of this in the future. So thank you again for coming.